Hi everyone, thank you for giving up your time this evening. I will try and keep it as short as I can, so I'm not taking your evening away from you. So yeah, I'm just going to go through a few of the conditions that you'll probably need to know about for the exam. I have gone through all the past med questions myself to get an idea of what they're sort of asking about, so I've got that on the next couple of slides. So topics wise, the next two slides just sort of show you conditions that you need to know about in the sort of like GP setting, or what you might come across that's referred from GP into A&E depending on what you need the MSRA for. So they're just for your reference. And what I'll do is I'll go through a few of the conditions, and there's either a question following the condition or a condition followed by an explanation of the condition after. So one of the major things that you probably will need to know about is the differences between osteoarthritis and rheumatoid arthritis. They probably will be two of the biggest conditions that present in a primary care setting, with complications presenting to orthopedics or rheumatology up in the hospital. So that's just a nice little summary diagram. In terms of what you're looking for on an X-ray, you're looking for the acronym LOSS, so loss of joint space, subchondral sclerosis, subchondral cysts, and osteophytes. And then on rheumatoid arthritis, it's pretty much the same, but you'll also get an inflamed synovium. What you're looking for in arthritis is it's usually affecting one joint on one side, not both sides. So it's symmetrical in RA versus OA. And also one of the major differences between the two is that in rheumatoid arthritis, you'll get morning stiffness, which lasts for a period of longer than 30 minutes. And it's caused by an autoimmune condition rather than being a degenerative disease. So osteoarthritis, as we said, degenerative condition, most common in elderly patients. So you'll get something in the vignette like you've got a 76-year-old lady who's presented to your practice with increasing knee pain over the last 2 months. It's worse on exercise, she's getting some swelling around the knee, that kind of thing. So symptoms: pain when they use the joint stiffness less than 30 minutes, swellings, bony enlargements of the hands, so that's all your different kinds of your Heberden's nodes. Causes are increasing age, so you're more likely to get it the older you are. Being overweight or obese because it causes excess stress on the joint, so loss of the cartilage and then rubbing of bone on bone, overuse of the joint, and the family history. Diagnosis is by clinical diagnosis, seeing the patient, and treatment can either be conservative, so just leaving the patient to see how they go, analgesia, exercise programs to help strengthen the muscles around the joint, or surgery. So this is just a nice summary of a sort of treatment algorithm in terms of what you can offer for a patient presenting with osteoarthritis. So you're starting off in the middle with advice for the patient, giving them some exercises, weight loss, so conservative measures, then moving on to your paracetamol, NSAID, Oromorph if need be, and then finally moving on, as you can see in the outer circle, onto joint arthroplasty and other measures such as support and braces for the patient. So first question: 55-year-old man, lives alone, complains of pain in his right knee, difficult to walk long distances, recent x-ray shows signs of OA, exam, mild medial joint line tenderness and stable ligaments, BMI is 25. What would be the treatment of choice for this patient? The answer was paracetamol and topical NSAIDs, which is the one that everyone seems to be going for. You could give NSAIDs by themselves, but obviously we need to think about gastroprotection, hence why there's also the NSAIDs with gastroprotection. But in your first instance, you'd probably go for the basic medications you could go for, which is paracetamol. Weight loss, potentially, but that patient is in the sort of normal BMI range, so together that probably wouldn't be the option. So yeah, paracetamol and topical NSAIDs. So rheumatoid arthritis, so it's a chronic condition, inflammatory condition affecting more than one joint. It can also affect the skin, the eyes, the lungs, the heart, and the blood vessels, so you can get extra-articular manifestations of the condition. You get joint swelling, pain and stiffness, as well as warmth of the joint. Patients might present with excessive tiredness, weight loss, dry eyes, as well as chest pain. You've got increased risk for women, or if you've got a family history, family member with rheumatoid arthritis, there's increased risk, as well as smokers have an increased risk. diagnosed by blood tests. So you want to look at their full blood count, their ESR, their CRP, rheumatoid factor, and then anti-CCP antibodies is the one that you really need to know about. This is the most sensitive and specific test for rheumatoid arthritis. And then you can get things like an X-ray and then specific tests like an MRI, moving on from the X-ray. Treatment, you're looking at disease-modifying anti-rheumatic drugs, so things like methotrexate, leflunomide, hydroxychloroquine, and sulfasalazine. Biological drugs such as infliximab, analgesia, steroids, physiotherapy, and surgery if it's indicated for the patient. So this is some specific hand changes that you need to know about. So we talked about Heberden's nodes and Bouchard's nodes. They're for osteoarthritis, and then you get some more specific ones in rheumatoid. So you've got a swollen neck deformity and the boutonniere deformity, which involves ulnar deviation of each of the digits. And then I've just included a little summary diagram of how you would go about therapy for patients with rheumatoid arthritis, like when you would add things in, monotherapy versus combination therapy, and what you do when the disease is established. This is quite a good slide to know, and it's from NICE guidelines. So another thing that you do need to know about is the treatment of hip fractures. So you probably won't get patients presenting to a GP setting with a hip fracture. Sometimes you might, as an anomaly, but most of the time they'll present to A&E. So your elderly patients having had a fall, potentially with a long lie, so thinking about CK rises as well. And what you need to distinguish between is the fracture that is intracapsular versus a fracture that's extracapsular, and that's just related to the blood supply. So for your intracapsular neck of femurs, you will be doing a half hip replacement. And for your extracapsulars, you're looking at doing some kind of fixation like a nail or a dynamic hip screw. What you can also consider is if the vignette says something like, you've got a 78-year-old lady, she's independent, still does all her activities of daily living, has a fall, she's got an intracapsular neck of femur. In her, you'd probably consider a total hip arthroplasty because she's still potentially got 15, 20 years of her life left and she's very independent. So you want to give her the best chance of gaining the best function back for her hip. So for her, you'd probably go onto a sort of total hip arthroplasty as well. And then in your younger patients, sometimes you might have to consider replacement of the hip joint as well to give them the best function. So again, another little diagram that just shows you the different types of fractures that you can get. So your 1, your 2, and your 3 are in that sort of intracapsular range, and then your extracapsular is 4 and 5 in terms of how you would fix them. Other arthritis-related conditions that you'd need to know about is psoriatic arthritis. So that's inflammatory arthritis that occurs with psoriasis, so skin changes. Ankylosing spondylitis, which is inflammation primarily in the spine, and that is when the patient will also present as HLA-B27 positive. You've got SLE, which is an autoimmune condition affecting many systems in the body, as summarised in the diagram on the right. And the classic thing that you'll see in that is the butterfly red rash appearance across the cheeks, which will be included somewhere in that vignette. And then you've got gout and pseudogout, and that's caused by excess uric acid versus calcium pyrophosphate crystals. So uric acid is gout, and the calcium pyrophosphate is pseudogout. So next question, you've got a 28-year-old woman who visits her GP complaining of pain in her joint. Previously sought medical attention for the issue, but high BMI was deemed the cause. She had a joint effusion in her knee and a limited range of movement. She's the MCPJ in her right hand appears swollen and her fingers have sausage-like appearance. Left hand shows nothing. She's tested positive for HLA-B27 and has a BP of 138/87 and a temp of 36/7. What is the most probable diagnosis? So yeah, the answer is psoriatic arthritis. I see a few people have kind of put RA and septic arthritis. So if we look at each one in turn, if you're struggling to decide between two, go through each of them. So it probably won't be osteoarthritis because she's 28, so we can probably safely rule that one out. There's no suggestion that she's had a history of gout, so I'd be quite confident to say that it's not gout. Then you're left with septic, psoriatic, and RA. So if we look at septic first, yes, she has a decreased range of movement, but her temperature is 36.7. So it's unlikely to be septic. She doesn't look as if she's clinically septic. So then that leaves psoriatic and RA. So yes, it could be RA, but the point in the question that they're looking towards is the sort of sausage-like appearance, which I think leads you towards psoriatic arthritis. So yeah, that's the answer for that one. So what is septic arthritis? So it's a very serious joint infection that has to be treated as soon as possible. It can be caused by infection spreading from another part of the body. You can have it from penetrating injuries, so something from out to in, and you can also get it with joint replacements. The most important thing to know about with joint replacements is any patients representing back to your clinic that have a non-native joint are presenting back to you with a non-native joint and you're suspecting septic arthritis, they must only be washed out in theatre. You cannot do an aspiration of the knee joint in a prosthesis because you will introduce infection and you'll create that biofilm that becomes very difficult to treat should the bugs attach to the prosthesis. So patients will have a swollen, hot and red joint with extreme pain on movement. The most likely cause is Staphylococcus aureus. And investigations, you can do a joint aspirate, imaging to look for effusion, say it's knee, effusion within the knee, and blood tests, so looking at your CRP, your white cell count, etc., as well as probably putting on uric acid just to rule out gout if someone presents it with a picture shown on the right. So, next question. 7-year-old girl from Sierra Leone, 2-week history of painful left leg. She's homozygous for sickle cell disease. On exam, she's febrile and there's bony tenderness over the left tibial shaft. Blood show hemoglobin of 6.9, gram-positive cocci, osteomyelitis of left tibia. What's the most likely responsible pathogen? The most likely response we've got is Staphylococcus aureus. And the next most common is non-typhi salmonella. Is anyone able to send a message in the chat as to why they thought Staphylococcus aureus and why they thought salmonella? Yeah, so we're saying salmonella due to this patient having sickle cell. So again, look back at the vignette. So it's very clearly saying someone from Sierra Leone, who's homozygous for sickle cell. So yes, normally Staphylococcus aureus is probably a most common pathogen for osteomyelitis, but given the history, it's most likely to be the salmonella as the cause. So that would be E. So then you've got osteoporosis. So this is a condition which weakens bone over time and makes them more likely to break. So patients will present with fragility fractures, so those hip fractures that we're talking about. Most common injuries are also broken wrists, hip fractures, and spinal fractures. It will be elderly patients, more common in women, patients on long-term steroids, inflammatory conditions, those with a family history, and those with a low BMI. So we had a 15-year-old boy with Duchenne muscular dystrophy on long-term steroids that actually presented following a fall after playing rugby at school, and he had an intercapsular neck femur fracture. So it can happen in any age group, those with long-term steroids. So diagnosis is by a DEXA scan of the whole body, and your treatment is with bisphosphonates to prevent bone resorption, biological drugs, calcium and vitamin D supplements because these patients will be lacking in those, and hormone replacement therapy. So a 6-year-old man discovered to have hypocalcemia during routine blood tests for CKD. He's got a medical history of polycystic kidney disease, and it's anticipated that the low calcium result is a complication of this. What abnormalities would you anticipate in his other lab values? I'm pretty sure the answer is E for this one. And this is because when you've got decreased calcium, your PTH hormone increases to start increasing calcium and vitamin D concentration, which can cause secondary increase in phosphate, as well as the increase in ALP. But yeah, this is a slide just to know if you learn by tables, this is pretty good way of remembering things. So you've got all the different types of conditions that you need to know about, as well as the calcium, phosphate, and ALP phos levels. So next condition is temporal arteritis. So it's conditions where the arteries at the side of the head become inflamed. Main symptoms is you get frequent severe headaches, pain or tenderness at the side of the scalp, jaw pain when eating or talking, and visual issues. Diagnosis is by a temporal artery biopsy and bloods. But even if a patient presents to you and you're suspicious of giant cell arteritis, you want to give them the high dose steroids to preserve their vision, because what you can get is you can get skip lesions within the temporal artery, which means that if you biopsy a part of the temporal artery that doesn't have the inflammation in it, and you don't think they've got the condition but they do, they could end up losing their vision. So it's very important, if you've got high suspicion for it, give them those steroids. So treatment is with high dose steroids, then they go on to low dose for a maintenance period, and then you get low dose aspirin, PPIs, bisphosphonate, and immunosuppressants as well, because it's a condition of the immune system. So next one, 60-year-old woman, ED with worsening headache for one day. She noticed that the pain, sorry, not Pauline, significantly worse when she was brushing her hair. She also complained of pain in her jaw when talking. Which of the following investigations is the gold standard test to confirm the suspected diagnosis? So the answer, the gold standard to diagnose is temporal artery biopsy. That's what the majority went for. Yes, you could do ESR and CRP, but without the temporal artery biopsy, it's only going to tell you that you've got some kind of inflammation somewhere without giving you the source. So one of the conditions that you need to know about as well is spinal canal stenosis, and it's quite important to know about this in relation to patients who also might present with cauda equina. So this is narrowing of the spinal canal, usually in the lower part of the back, which causes compression on the spinal cord, most commonly due to osteoarthritis, and the common age to occur is 50 years plus, with women being more common than men. Other causes can be a narrow spinal canal, injury to the spine, a tumour which obviously impinges on the spinal cord, rheumatoid arthritis and previous surgery. Patients will present with back pain, sciatica, numbness, tingling, cramping, weakness, loss of sensation in their feet, loss of sexual function, loss of bowel and bladder control. So it's important to distinguish this from cauda equina. Diagnosis is by an MRI, and treatment is with physio-analgesia and sometimes surgery if decompression is needed as a final option. Usually in the vignette, you will get something about a patient who's slightly older, pain in their lower back, relieved by standing up and leaning forward in comparison to sitting down, because it helps create a bigger space within the spinal canal for the cord to stop the impingement from occurring. Hence this question. So a 49-year-old man, difficulty walking, experiencing pain in both calves and feet. Pain disappears completely after he sits and rests for a few minutes, and he's found that sitting down, not standing up, leaning forward helps him with walk further before the pain returns. No paramedical history and no physical exam, no abnormalities. Probable diagnosis. Yep, so diagnosis is lumbar spine stenosis. As I said, it's got that little bit in the middle. The leaning forward and the sitting down helps with the pain, because it helps create extra space within the spinal canal to allow for comfort. So bone tumours is something you also need to know about. So patients will present with pain. It's not associated with movement, and it can be worse at night. They may present with a palpable mass. It can also be present as a pathological fracture. So if a patient has a fracture within a bone, like a lytic or sclerotic lesion, it could present as a neck and femur fracture because of the lesion within the bone. And investigations would be X-ray, MRI, or a bone biopsy. So the diagram on the right, apologise because it cuts off some of it, it just shows you the different types of bone tumours that you can get, and whereabouts you get them in relation to metastasis, diaphysis, and the epiphysis of the bone as well. So 13-year-old comes to her doctor with a 5-month history of aching pain and swelling in the distal part of her left thigh. She's got a family history of retinoblastomas and good health otherwise. An X-ray of her knee shows a sunburst pattern and a triangular area of subperiosteal bone in the metaphyseal region of the femur. What's the most probable diagnosis? So next condition is something called polymyalgia rheumatica. So this is where patients get stiffness in the morning, which can last longer than 45 minutes. They get extreme tiredness, weight loss, depression, loss of appetite. Most patients that are diagnosed are over the age of 65, and it's more common in women than in men. Prednisolone is the main treatment to help with any sort of inflammation that the patient's getting. But they can also go on to develop temporal arteritis, so it's quite important to be able to recognise that early. So the diagram on the right just is a quick summary of how you would diagnose and what sort of treatment that you can give for the patient and why it happens. So next one. So related to spinal canal stenosis, we had cauda equina syndrome. So that's where there is dysfunction of multiple lumbar and sacral nerve roots of the cauda equina, which is where obviously the spinal cord spreads out at the bottom, like a horse's tail, thus the name. So what can cause it is spinal lesions and tumours, causing compression, infections around about the cauda equina, lumbar spinal stenosis, so it can cause cauda equina syndrome, but this is where it's important to correlate the clinical findings and how long the patient has had the clinical findings for. Birth abnormalities, post-op spinal surgery, complications, and spinal anaesthesia. So patients will get urinary retention, so it has to be more than 200 mils to be considered urinary retention for catheterization where I work. Urinary or fecal incontinence, saddle anaesthesia from front to back, weakness and paralysis of more than one nerve root, pain in the back and the legs, or sexual dysfunction. And diagnosis is your history and exams, your clinical findings, and then you'd probably move on to getting an MRI for the patient if you were concerned, a CT if you didn't have access to MRI. And treatment is urgent or emergency surgery for decompression if it's indicated. Most of the patients that come through the door would probably just end up getting pain control and physio of some description. They don't tend to have compression of the cauda equina, or if a patient presents, they've got compression of the cauda equina on their scan, but they don't have any clinical symptoms, there's no indication to do a decompression at that point. So next one. So two other conditions, one of the most commonly occurring is median lateral epicondylitis of the elbow, so golfers and tennis elbow. That comes up several times in several different ways to do with what movements the patients have difficulty with. Hence this question. 48-year-old man presents painful erythematous fluctuant swelling over the posterior elbow, no history of trauma, in good health, and has full range of movement. What's the most probable diagnosis? Okay. Yep, so lectron bursitis. And that's because it's usually occurs as well of an atraumatic. Atraumatic, so there's no injury preceding the development of the swelling over the bursa by the elbow, and patients also probably have full range of movement. So SLE is another condition. It's the most common form of lupus. It's an autoimmune disease where immune system attacks its own tissues, causing widespread inflammation, affecting the skin, lungs, brain, blood vessels, joints. Patients present with fatigue, skin rashes, fever, pain, swelling in their joints, and it comes in flares. And the treatment is immunosuppressants, and hydroxychloroquine, which you need retinal screening for before you start the patient on it, and prednisolone. So next one. So your foundation doctor in the ED, you tasked to assess a 26-year-old man who fell on his right ankle whilst intoxicated. According to the patient, he was able to wait there after the incident and continued his night out. However, he woke up with ankle swelling and pain. You saw minimal bruising and swelling, but there's general tenderness and good mobility. What imaging modality would you recommend in this case? This one would be, and I've got a slide, I think, to explain this in the next one, no imaging. This is because the patient from the vignette, he's mobilised on his ankle the night before. And yes, there's swelling and pain, but they're saying that he's still got good mobility on it. So he's unlikely to have a fracture. It could be some kind of soft tissue injury or a ligamentous injury. But in terms of imaging for the bone, it's not indicated in this scenario, which I've shown here. So these are the rules that you need to look at. So on the lateral view, it's when patients got tenderness at A, or B, and an inability to weight bear immediately after the injury and in the emergency department. So because he's weight bared, we've not needed to do an x-ray. That's been the indication. And on the medial view, you've got your indications for doing an x-ray there as well. So 56-year-old man recuperating after experiencing initial bout of gout. He continues to experience some persistent discomfort in his big toe. No predisposing factors and no signs of gouty tophi. At what point would be appropriate to initiate uric acid lowering treatment? Yep, so the answer is once his symptoms of acute gout have resolved. The next slide, we'll go through gout, but I've also got a algorithm for treatment. So gout's where there's urate crystals that accumulate in the joint, causing intense pain and inflammation. Risks are diet, increased weight, medical conditions such as hypertension, medications such as ACE inhibitors, family history, males are more common than females, and recent surgery. Diagnosis is by joint aspiration, so a patient will probably present to GP and get referred on to A&E that have a swollen knee joint that's hot to touch and painful. Bloods, so you're looking at your uric acid, and an x-ray to look for any effusion in the joint. Treatment is with your typical NSAID, colchicine or corticosteroids, and preventative measures such as allopurinol, febuxostat and probenecid, which helps remove excess acid. So this is a treatment algorithm which I think it got off nice. So I would just have a look going through that in terms of when it says to start management of treatment and first line, second line. So pseudogout, it's due to deposition of the calcium pyrophosphate crystals. It's commonly seen affecting wrists and the knees. You get sudden intense joint pain, swollen joints, red skin over the affected joint, and can be caused by hyperparathyroidism, hypomagnesemia, hypophosphatemia, hypothyroidism, and hemochromatosis. Diagnosis is again by joint aspiration, which will show the calcium pyrophosphate crystals, and treatment is again with a colchicine, anti-inflammatories, and steroids. And this is just a nice little summary slide of the differences between gout and pseudogout, who gets it, what the risk factors, how they present, and what you see on the crystals. So next question, 60-year-old man complains of worsening pain, swelling in both knees with stiffness and decreased mobility. He's got painful wrist joints with nodules at the proximal and distal interphalangeal joints, which have developed slowly over the past 2 years. What's the diagnosis that's most likely? Okay, yeah, so the answer is osteoarthritis. What leads you to that is probably the age of the patient. He's got pain in both knees, decreased stiffness, decreased mobility over the past 8 months, so a longer time period. He's got nodules at the proximal and distal interphalangeal joints, which probably the different nodes that we spoke about. So that's and given his age, it's probably more likely to be osteoarthritis than rheumatoid as a first presentation. So 56-year-old man, GP complaining of numbness and tingling in his thumb, middle and index fingers. This is beginning to interfere with his work. He has a history of hypothyroid, which takes thyroxine. Other than that, his medical history is unremarkable. Which nerves are likely affected? The answer is the median nerve. So that's the main nerve which gives the sensory abnormalities over the thumb, middle and index fingers, as it says in the question. So these two slides just summarise the nerves that you need to know about in their courses in the upper limb as well as in the lower limb. So I'd suggest just having a quick look at them. The last question, you've got a 7-year-old girl who's referred to the peds emergency department by her GP with a 4-day history of fever. She's got bilateral conjunctival injection, maculopapular rash across her trunk and erythematous extremities. Her chest is clear and her heart sounds are normal. Her abdomen soft and tender and her lips look cracked and her tongue is erythematous. No palpable lymphadenopathy, which the following blood test results would support the likely diagnosis for the patient. Yeah, so the answer is E, thrombocytosis that you see in Kawasaki disease. So the final slide just is a quick summary of Kawasaki disease. So someone's talked to me before to remember the rash. If you think of your points of contact on a Kawasaki motorbike, is your hands and your feet, which is where they get the rash. It affects children under the age of 5. They get a temperature lasting for 5 days or longer, rash, swollen glands, dry and cracked lips. Strawberry tongue is one of the main signs as well that they probably say. Red inside the mouth and the back of the throat, swollen hands and feet, and red eyes. Treatment is with IVIG, aspirin, which is the only time that you can give aspirin in children because of risk of Raynaud syndrome, and corticosteroids. Complications can be cardiac issues, and causes are genetics or infection.
I just want to also say thank you again to everyone. Thank you, everyone. If we can all give it firstly to you for coming. Also, thank you for Rachel to give up her time. She's put a lot of time and effort into making these slides.